So welcome back, Associate Professor Bronte Holt, this time talking to us about emergencies and for colonoscopy, so acute lower GI bleed, perforation, and pseudo-obstruction. Thank you, Bronte.
So with this emergency in colonoscopy talk, I'm going to talk about three main areas: acute lower GI bleeding, perforation, and acute pseudo-obstruction. So when I was thinking about this topic, I was like, well, what's going to be a 000 call for acute lower GI bleeding? And the way that we can think of these causes of acute lower GI bleeding is vascular. So is this from an AVM or is it a diverticulosis? And this is actually the most common cause of a acute lower GI bleed. It accounts for 30 to 40% of cases. It's actually a rare complication of the disease. It's just that diverticulosis is very common, particularly in Western populations. It typically occurs in the absence of diverticulitis. Diverticulum often develop at the site of an arterial vascular penetration. So a diverticular bleed may be large volume and arterial in nature. Right-sided bleeding is more common than left-sided diverticular bleeding because the wall of the bowel there is thinner. It's usually self-limited. So if a patient presents with a diverticular bleed, it will often settle down in 70 to 80% of cases. Rebleeding, however, occurs in 40% of those patients. So if you've had a patient with a diverticular bleed, you can tell them, yep, it's a good chance, 40% chance that this may happen again. The other vascular lesions are, so we've mentioned angiodysplasia, also ischemic and radiation-induced. The most common out of those are angiodysplasia or AVMs. AVMs are particularly common in patients more than 65 years old. So AVMs are dilated, tortuous, superficial blood vessels which are epithelial lined, so they're not muscular lined. Bleeding, therefore, is venous, and so it's usually low volume and rarely results in a 000 call. It's treated by colonoscopy with APC, but this is usually done on an outpatient basis and not as an emergency. Hemorrhoids can sometimes present with a large volume bleed, but generally it's very uncommon to be large enough to be causing any hemodynamic instability, but it can cause a large volume loss over time. Inflammatory causes such as colitis are usually associated with other clinical symptoms that would sort of point towards the etiology. And then there's neoplastic bleeding as well, so from malignancies. These are really anyone that's gone through residency will sort of know these steps of the management of acute GI bleeding. These are the features, however, that can predict worse outcome with an acute lower GI bleeding. If the patient has hemodynamic instability, they have persistent bleeding, significant comorbidities, and advancing age. Bleeding in a hospitalised patient is also a poor predictor. A history of previous diverticular disease and angiodysplasia-related bleeding. If they're on current aspirin, and I would sort of add to this any blood thinners. If their blood results show essentially that they're sick, so an elevated INR, hypoalbuminemia, anemia, elevated urea, so renal impairment, and abnormal white cell count. Also a predictor of worse outcome is a non-tender abdomen and no diarrhea, as these are otherwise treated by different mechanisms. If a patient is hemodynamically stable and present with an acute GI bleed, then these are patients who would go for a colonoscopy and try and identify the source. If it's identified, for example, it's a diverticular bleed or an AVM, then we would simply treat it. If a source hasn't been identified, then we need to sort of figure out where it's come from. If the episode's isolated, self-limited, and they don't have iron deficiency anemia, if it was isolated, self-limited, and not associated with iron deficiency, then we would have expected management. If, however, any of those were present, then we would have an upper endoscopy, look for a source from the upper end. And if no source has been found at the top as well, then we would evaluate for small bowel bleeding. If a patient is unstable and presents with acute lower GI bleeding, then our guidelines would suggest following resuscitation, then we really need to talk with our colleagues because these are patients that may not be suitable for a hot colonoscopy. So consult with surgery just in case it's needed and or interventional radiology. They may be looking at doing a CT angiography or direct to DSA. Perform an upper endoscopy once they're hemodynamically stable, because if they're unstable, there's a good chance it's actually an upper GI source. If there's no source on the gastroscopy and the bleeding continues, then we would do a CT angiogram to locate it. Because this is basically saying that if someone's having a really large volume and that unstable bleed, you don't want to go in and do a colonoscopy, because it's probably probably going to be from higher up, or something that you're not well enough equipped to treat compared to interventional radiology who would do embolization. This is the diverticular bleeds. So diverticulum don't have a muscle layer. So these are outpouchings, and because of the thinned layer within the diverticulum, this is what predisposes them to the bleed. So we've got to be really careful in treating anything within a diverticulum. If the bleed is at the neck of the diverticulum, then there should be some muscle underneath it, and you can treat it either with clipping or banding. Very judicious use of diathermy. If it's at the base of the diverticulum, then you need to be very careful of using any diathermy techniques, and it's more a clip-based approach if you can get to it. Studies have described as well using the band technique. I've not personally done this, but it's very effective if you're able to get a colonoscope with a banding system up to the bleeding diverticulum. And you can see on the image down the bottom what they've actually placed a clip first to help localize it with their diagnostic colonoscope. Then when they've gone back with the bander, that allows for easy identification of that's the culprit lesion. Because when someone's got active bleeding due to diverticulitis or diverticulosis, often it can be really difficult because all the diverticulum are full of blood. So it's hard to know which one is the culprit one. And then this is the, I think that's the same, pretty much the same image actually. There you go. The further thing that I wanted to briefly touch on is AVMs. This is a examination here that shows a rectal radiation proctitis. But the treatment is the same for AVMs throughout the colon. In the rectum, when we do APC or argon plasma coagulation, typically we wouldn't inject beforehand. But if I find AVMs in the right side of the colon, I will always do a small volume saline injection underneath the lesion, because you can perforate these patients, so they can have a microperforation, so it just increases the safety. The top images are actually from the APC, from the IRBI website, and they talk about the different thermal tissue sensitivities throughout the gut. So when you're in the colon, it's sort of a moderate sensitivity. So this is where you need to dial down the heat that's used. Whereas in the stomach, because of the thick muscle layer, you can use a higher wattage for the APC. And so if I'm in the colon, I would typically set my monitor at 30 watts and at 0.8 litres per minute. And then if you're simply not achieving any burn, then I would increase the wattage by 5. And this is a non-contact procedure. It's really important to know and understand what sort of APC device you've been given. The most common would be a forward shooter. That's where the argon comes out through the tip. And then you can also get ones which have got like a little rubber ball, like a little ball on the end where they go side scatter. And then you've got other ones which are side shooters. So you need to know what you're being given by your nursing assistant. And you want to ideally maintain a short distance between your mucosal surface and your device before applying APC. If you do get if you do touch the surface, there's two issues. You get coagulum onto the tip of your catheter, which can mean that your arcing is not as sort of predictable. But the other thing is then you get argon gas into the submucosal layer of the colon, which we want to avoid. Then the next 000 call would be colonic perforation. Now, colonic perforation is typically not an endoscopic problem. This is where we would be calling our surgical colleagues, or ED would. But there are some times where we might be involved, and this is mainly if it's been an intraprocedural and they've had a delayed presentation. So they present with acute abdominal pain, peritonism, fever, sepsis. They may or may not present with those features, but it's typically abdominal pain and all. They'll have a CT scan, which will typically show some extraluminal gas. I think many of us who do snare resection and EMR will have had a patient or two where there's been some microperforation. And those ones you can often treat conservatively. So post-procedurally, it may be from a resection, but it actually may be from your scope, from the shaft to your scope, with a luminal tear or a splenic laceration. It may be from a diverticular perforation or acute colitis. If it's a post-endoscopic resection, then I would encourage consider an urgent colonoscopy if it's been less than 24 hours since it occurred and it's a contained perforation. This is a prospective multi-centre registry published recently in Surgical Endoscopy. I believe it was from Korea, and essentially they looked at 84,000 patients across multiple centres, and they were prospectively evaluating which patients had perforated. So they had a dedicated nurse at each site who were collecting this information, and they found that perforation was more common in therapeutic colonoscopy. It sort of makes sense. However, if it occurs during a therapeutic procedure, the outcomes are better, because that makes sense as well. If you've had a perforation while you're doing a resection, you can close it up at the time. And typically, if it's a more complex resection, it's someone who knows how to use clips and is very comfortable in that sort of circumstance. If it's occurring during a diagnostic procedure, it's typically from the shaft of the scope. So it's an injury from the actual scope itself, and it's more common at the sigmoid colon and at the flexures. Risk factors for patients requiring a prolonged admission in the hospital is a sigmoid perforation. If there's been a delayed recognition, so this is why we need to monitor the patients in recovery afterwards, and they have abdominal tenderness, because that's a marker of peritonism. Predictors of patients needing surgery is it was a diagnostic procedure because it's a shaft-related tear and rebound tenderness. How am I going for time? I'll just very quickly go through. This is another large study which was looking at the characteristics and treatment of both interventional and non-interventional iatrogenic perforations, and essentially, most of the patients who had non-interventional perforations required surgical procedures. My last sort of thing I wanted to touch on is acute colonic pseudo-obstruction. I must admit I didn't know a huge amount of this. I don't think we see it that often. So pseudo-obstruction is dilation of the large bowel in the absence of an anatomic obstruction. It presents with signs and symptoms of bowel obstruction, so abdominal pain, nausea and vomiting. They have an X-ray or CT imaging that shows proximal colonic bowel dilation. It can be acute or chronic. So chronic intestinal pseudo-obstruction is, or SIBO, is typically associated with some neurological diseases such as Hirschsprung's disease and Parkinson's disease. But acute colonic pseudo-obstruction is a different sort of kettle of fish. So this is a case report from New England Journal of Medicine in an unwell inpatient in hospital who developed abdominal pain and vomiting. And this is the classic X-ray imaging of the dilated colon. And this is known as Ogilvie syndrome. It most commonly affects the large intestines from the cecum to the splenic flexure. We don't know the pathophysiology. It's thought to be due to autonomic nervous system dysregulation. It mainly presents with inpatients, so those that have had surgery or are critically unwell, and symptoms can occur rapidly or progress slightly slower over a few days. If they have fever, severe abdominal pain or peritonitis, this indicates ischemia of the gut or perforation, and so they should be very closely evaluated for potential surgery. The initial management is with bowel rest, and they need some bloods taken. And then management is identifying the contributing factors, so correct electrolyte abnormalities, make sure there's no infection on board that's contributing, such as C. diff, and look at the medications. So anticholinergics and opioids are associated with this condition. Place a nasogastric tube to decompress the gut. A rectal tube can be placed on dependent drainage, and then it's treated conservatively if they seem to be uncomplicated, and will often resolve. So if the patient's cecum is not particularly dilated, it's less than 12 millimetres. Is that correct? No, 20 I think it's meant to be. No, 12. There's no ischemia, peritonitis or significant pain, and this has a high success rate, around 77 to 96%. So the next stage, if that's successful, then we consider low-dose PEG administration to keep the bowels moving. If, however, they have only a partial response or no response, then we use neostigmine, and this is only as long as they don't have any contraindications to it. It's given as a slow push on a telemetry bed, and it's effective in 85 to 94% of patients. If that goes well, you can then essentially give them some PEG and away we go. If not, then colonoscopy is performed for decompression. Thank you.